Hi, everybody. It's 7 p.m. in Paris, noon in Nashville, and it's my great pleasure to welcome you all to this new journal club by the International Academy for Clinical Hematology. I'm Mohamad Mohty from the Sorbonne University in Paris in France, and it is really a true pleasure to welcome Professor Elie Azoulay, who is head of the intensive care department at the St. Louis Hospital in Paris. And I'd like also to welcome Dr. Olalekan Oluwole, who is the director of the CAR-T cell program at Vanderbilt University and Health Systems in Nashville in the US. This is our traditional journal club every 15 days. We're very grateful to Takeda Oncology for supporting this ICH Journal Club. For today's Journal Club, the steering committee has selected this article recently published by Professor Azoulay and colleagues in the Lancet Hematology. And you can see the title. This is about the outcomes in patients treated with CAR-T cell therapy who were admitted to intensive care. And this is a so-called CARTTAS or CARTTAS study, which is an international multi-center observational cohort study. This is the abstract of this work, and you can see this is an amazing number of intensive care units, 21 in different countries across the globe. And they have analyzed 942 patients who received CAR-T cells, of whom actually 258 required admission to intensive care. And to make a long story short, actually what's really important and novel finding in this work is that the authors could find that the 90-day mortality after CAR-T cell infusion is highly influenced by the frailty status, but also by bacterial infections and life-saving therapy requirement within 24 hours of admission. You can see this is one selected figure from the article, and you can appreciate the issue of sepsis and the predicted risk for 90-day mortality compared to if you look to isolated cytokine release syndrome or isolated ICANS or neurotoxicity. And I think these data are of great importance because, first of all, and we'll discuss this with our panelists, they are quite unique, actually, and they will have some significant implication because the impact of frailty on mortality would probably mandate some very rigorous selection of these patients, but also the issue of bacterial infections should not be neglected. And I believe this is crucial because CAR-T cell therapy is here to stay, and this has been a true revolution in the field of hematology and hopefully in solid tumor at some point. And this is why I think refining and optimizing the management of these patients when they will require intensive care is absolutely crucial. So I'm really very grateful to Professor Azoulay, who is the first author who led this work. Elie, welcome and thank you for making the time. I know you're busy and you're on duty, but we're very grateful.
Thank you, I'm delighted.
And Dr. Oluwole, thank you very much for joining us and for accepting to share your expertise. So actually, my first question is going to be to Dr. Oluwole. I mean, you didn't contribute to this work, so you are sort of an outside observer. So what were your thoughts? What was your first reactions when you have seen this paper published?
Yes, this is one of those aha papers that, we've been kind of wishing that we knew or had in some shape or form, we've all treated patients with CAR-T. We know some of them have the unfortunate experience of going to the ICU. We know it is life-saving therapy, but we wonder what is the impact of all these escalations of interventions that we see. And it is really great to have a good number sample size study that is multinational to actually tell us something where we previously didn't have any information at all. I particularly like the fact that it is multinational, not just multi-institution, multinational, and it's really well designed that they paid attention to certain areas with the understanding of differences in regions and so on. And I like the fact that it had an adequate sample size. So not just taking a crack, but actually making a good faith effort to summarize some data and present to us. It was really great from that perspective.
Thank you very much. And here I'd like to remind our audience that you can, of course, participate and ask your questions or post your comments on the chat box or using the Q&A box, and I'll do my best to share it with our panelists. So now my question is to you, Elie, is about the rationale and why did you do this work? Because my understanding, I was a bit surprised seeing it, because I thought that a few years ago, you have published some fantastic work looking into the outcome of hematologic malignancy patient going to ICU, more than 1,000 patients. So I thought we already got the answer. Why did you want to revisit this with CAR-T cells?
So thank you, Mohamad, for inviting me. Well, I believe that we were committed to provide data, and we have been using CAR-T cells since a few years. And as an ICU specialist, we have been involved at different levels for not only getting to the selection of patients, but also to early target to find the appropriate thresholds for ICU admission. So our group, that is called the 9I, is a group of ICU physicians all over the world interested in improving outcomes in hemato patients, but also other immunocompromised patients. By our discussions, we were quite surprised to see that we were targeting ICU admission for different thresholds of severity. So this is one. Two is that we were also very much varying with our practices of using tocilizumab, for example, or for starting vasopressors. And that was another surprise, because for the initial patients, we were very much guided by trials and protocols that were mentioned in the pivot trials that led to the drugs released in the market. But now we are more into the real life situation. So we wanted to see what were the differences. And the last thing is about patient selection, how this selection actually impacts on the results of our procedures when the patients are critically ill. So the real reason why we did that is that we have a strong belief that we can learn from each other, from the variation, but also from this international collaboration. And I agree with Dr. Oluwole that we learn a lot from each other, and this is how we get to this paper.
Excellent. And actually, I was personally very pleased to see that compared to some retrospective and historical data in such a large series, actually the overall CAR-T cell mortality by day 90 is relatively low, I think. Of course, you are highlighting that we have roughly 22% of mortality, but this is in the group who were admitted. So if we take the whole patient as a denominator, we are around 5%. Do you confirm, Elie?
Yeah, I do confirm, and I think that you are raising a very important point, is that for the time we have admitted the patients over the 30 days that followed CAR infusion, no one died in the wards without getting to the ICU. So this strengthens even your comment, making that it's very clear that mortality in these patients with refractory malignancies is actually low and is not only related to ICU mortality. That was, we only had 14 patients dying in the ICU, but it also includes mortality related to CAR failures.
So, Dr. Oluwole, when you read this paper and when you looked, of course, we had 21 centers, maybe, I didn't count them, 9, 10 different countries. Were you able to recognize your own practice, among what is being done in this paper? And what's your current practice, actually, compared to what is described in the paper in terms of time to admission, criteria for selection? Can you please share this information with us?
Oh, there are many things to unpack from that. But before I go to your question, I just want to make a comment that is not immediately obvious. And we know that these are patients with relapsed and probably refractory lymphoma, and most likely large cell for the most part, although I know there were some multiple myeloma patients in there. Based on the scholar data and the really low likelihood of response, like 26% to next line, and median OS of about 6 months, it is really interesting to see that the CAR-T related mortality is this low. So it does mean that the CAR-T has actually had an impact. If you model it, it speaks to the paradigm changing impact of CAR-T in this particular very sick population. Now, to answer your question, of course, we've treated patients and we've seen people go to the ICU. We didn't have this data, right, until this was published, the multinational part. But we have actually made multiple changes in our own process to the way we treat CARs. So the way we approach our patients at Vanderbilt, being a comprehensive cancer center, is a little bit different in the sense that some of our guesses that we had kind of implemented make us do things a little bit differently. For starters, we actually do our frailty assessment at the time of screening for the CAR-T. And the advantage of that is that it actually gives us time to make an intervention with the frailty score, and we use the geriatric assessment. And there are a few other frailty scores out there. We actually have a faculty member who actually spearheads that. So we identify the frailties and have some time to intervene on it before they reach lymphodepleting chemotherapy. And it is good to actually see that perhaps that may have an impact rather than these patients that got their frailty assessment probably when they were already hospitalized for the CAR-T, which will leave little intervention for that. Secondly, the place where we house our CAR-T is more like a step-down unit type of a situation. And many times we don't have to transfer them to the ICU because the degree of monitoring that they need is available. We can do a fixed low dose pressure and we can manage them up at the ICANS grade 2, maybe even a few grade 3 in our step down unit. And I know that type of variation was accommodated for in the modeling because there are different regions that manage things a little bit differently. So those are just some of the things that we do. And our real ICU transfers is a lot lower than what is published simply because we do the outpatient frailty assessment and so on. Lastly, antibiotics. So we have protocols for managing neutropenic fever. Any CAR-T patient that comes with a fever is automatically escalated. And why is that? The fludarabine and cyclophosphamide, which are by far the most often used lymphodepleting regimens, is, even though it's 3 days, is often sufficient to cause grade 4 neutropenia. So we just manage them like that, and they are for the most part on broad spectrum antibiotics at the first fever. So, and I know not everywhere does things like that. It's just some of the things that we do here that is a little bit different than what may be done elsewhere. Thank you.
We'll come back to this. We have actually 2 important questions from the audience, which I think are really relevant. First question is from Dr. Waishai Shin Ratanalab. Hopefully I'm pronouncing it well. And this is to Elie. what is the percentage of patients who died of progressive disease in the ICU, where you would consider that the cause of death is actually the disease, although they were admitted to ICU?
But this is a very important question. It's 1/3 of the patients. So in the ICU, we have 14 patients who died, which is quite low. And among them, 1/3 of them died from disease progression and from refractoriness. And these patients had actually a protracted ICU courses. But Mohamad, I hope you can give me the opportunity to reply to Dr. Oluwole, because
please,
I adore what you just said, because we are really working on this since a while. So I appreciate that you have step-down units that you can convert the level of monitoring and give specific therapies. That exists also in Europe, in Germany, for example. But I think that there are studies that show that giving vasopressors is not a simple therapy. It has to be performed by ICU specialists. You have to monitor resistances. You have to monitor cardiac function. You have to monitor fluid volumes and whether you can expand or not. And you have to monitor the cardiac function before giving pressors. And I think that this is not only something you need to do once you start, but also when you give the treatment. And I'm sure that the results you have by giving vasopressors in a hemato environment are not the same than the one that are given in an ICU environment. The second thing is, I also appreciate what you just mentioned on bacterial infection. And this is true, as you just said, because of the lymphodepletion, 70% of the patients were neutropenic when they came to the ICU. However, the treatment of bacterial infection is not only antibiotics, it's source control. And I think that this is a major message from this paper, is that besides escalating to, to another range, to another, or maybe to combination therapy, despite the very low evidence for adding aminoglycoside or any additional antibiotic therapy in this setting, I think that we need to control the source. And of course, it can be done anywhere, but it's just a message that targets that bacterial infection also needs to have another specific management that we are used to do. And the last thing is about frailty. And I think that this is the first paper that gets out from performance status and ECOG status and getting to frailty. And I believe that we should not exclude frail patients or frailest patients from the CAR T-cell therapy. We just need to know that from the beginning and maybe offer them another kind of monitoring and another kind of thresholds for ICU admission.
So that brings us actually to the again and again to the personalized treatment approach. Absolutely. So let's stay a little bit in this issue of infection and antibiotics, because I believe this is going to be really a big matter of concern, because the big number of patients who are going to receive CAR T cells in the next few months, I think, are going to be the myeloma patient, because we are lucky, I think, in the community, having the first approval of a CAR T cell in multiple myeloma a few weeks ago, the ID-cell product, thanks to the KarMMa trial. And actually, in terms of numbers, given the label of this CAR T cell, this product, the ID-cell, I do anticipate that the myeloma patient will represent a huge amount of patients. And we know very well they are even more highly immunosuppressed compared to lymphoma or ALL. They have received tons of dexamethasone, which is really huge. And we know, just looking into the COVID-19 experience, unfortunately, the highest mortality rate is among myeloma patients, not actually in acute leukemia or MDS. So with this in mind, I'd like to ask you, Elie, again, how would you expect this issue of immune suppression and how to handle it, especially that, in my opinion, it will be unlikely that we are going to make it homogeneous in terms of antibiotics practice, worldwide. So when it comes to source control, I'd like you to expand a little bit, and because otherwise the good numbers we're talking now may become a little bit, may worsen in the near future.
Well, that is a very important point. I would say that there are two approaches. One is the risk stratification for sepsis that should be assessed at the time of eligibility. So what we do is when the patient comes for apheresis, he sees, so we do that with an ICU specialist, but it could be an ID specialist knowing, the risks. So someone, I would say external to the hematoconsultant, should assess the patient for the risk of developing bacterial, viral, and fungal infection. This risk is, as you just mentioned, based on the number of line and courses of chemotherapy, of targeted therapy, also maybe whether the patient has received a high dose intensification or maybe sometimes a BMT. And the other thing is also based for myeloma patients on the level of gamma globulins, which should be really taken into account. And I don't think that everything is about providing gamma globulin, but is also thinking on the risk for bacterial infection in this very specific group. So the other thing is that we need to balance the use of ICU resources for myeloma CAR-T recipients. They will develop quite low rate of severe CRS. They will have a certain kind of toxicity, but of neurotoxicity, but the ICANS overall will be less severe, but we will have them for more sepsis, something on which I agree. And I must say that for sepsis, the results of the ICU, the use of an ICU resource for myeloma patients are quite good, because this is again standardized. So to come back to your specific point on source control in myeloma patients, there are two things on which we really need to pay attention. One is about the catheter, and I think that there is a high risk of catheter-related infection. I don't think we should be hysterical about it, but we just need to bear it in mind, and when we have the patient, to look at it. And the second thing is, you mentioned the differences between myeloma and others, but they are also elderly as compared to patients with leukemia or other groups. And I think that cardiac dysfunction is another player in the management of patients with myeloma. So we need to take this into account.
So Dr. Oluwole, how would you anticipate the evolution of the toxicity and mortality with the advent of these myeloma CAR T cells with more frail patient, more immunosuppressed, and as Elie mentioned, they are even older, because median age of myeloma at diagnosis is 70. So we get them at relapse refractory settings. So probably the median age is going to be 74 or 75. Any thoughts on this?
Oh, by the way, that is one of the strengths of CAR-T therapy. There is no age limit. People can age out of transplant for multiple myeloma. That said, Elie is completely right in his assessment that it's going to shift a little bit from higher grade CRS to more severe microbial infections. Now, it's interesting that we have so many guidelines for CRS and ICANS. We have ASTCT, we have so many of them. We have very few for infectious agents management in the setting of CAR-T, and that is an area of need. Secondly, the frailty score, probably we need to come up with a consensus guidelines around that as well, particularly moving it earlier on, including some form of rehab, physical therapy, or other things like that. Because although we know off-the-shelf CARs are coming, but they are not yet mainstream, at least there's some downtime between apheresis and infusion of CARs right now. That is prime opportune time to intervene to make them less frail. By the time they get the CAR-T, they may be little things, but I think they would go a long way. Then there are some yes or no questions. Should we use prophylactic antibiotics in everybody? And should they stay like within an hour of the treatment center for a month? I mean, things like that will be what we need to try and see whether they make sense or not in this particular population, because we figured out a little bit how to give 2C and how to manage all the ICANS, but the infections will remain a concern.
Okay, so thank you very much. That's very clear. We have a few questions from the audience. We have one question from Dr. Vishvadeep Kusho. I hope I'm pronouncing well, which is about something that can be related to the infection issue, about the prolonged bone marrow suppression. Because after fludarabine and cyclophosphamide, we've seen patients, leukopenic, cytopenic, even requiring transfusions? Is this something that is a contributing factor? Is this something that is maybe, although it wasn't clearly shown as it is in the paper, is this something that is contributing, Elie?
Well, I believe that this is more a question for you, because we are more into the first days that follow CAR infusion. When we compared patients with bacterial infection to patients with no infection, or to patients with sepsis that includes documented and not documented infections versus other patients, we were not able to recognize neutropenia or cytopenia as overall as a risk factor for that. And I think that we are in very specialized centers where neutropenia is not anymore a risk factor for mortality when patients are in the ICU. Because of the standardized management, we are making everything to avoid delaying antibiotics and source control. So I believe that the problem is just what you mentioned, Mohamad, at the beginning, is that we are going to see CAR-T generalized into new indications of people maybe less used to manage patients with neutropenia. And then I think that we are going to have another player, which will be the case volume or the experience. So when CAR-T cell will move to the oncology field, or maybe sometime, you know, we can see some promising indications outside the hemato-onco world. So I believe that then these factors that are not players in our world of hematology will be players in oncology or in other specialties.
Okay, thank you very much. Let's dig a little bit deeper into the process of patient selection and frailty assessment. And I personally believe exactly what you mentioned, both of you, that age by itself should not be a limiting factor. It's more about adjusting our treatment. So do you think, and Dr. Oluwole, you mentioned the need for a consensus about scoring, whatever. I mean, I know many colleagues, many centers are simply extrapolating what we know from allogenic stem cell transplant, you know, the Charlson comorbidity index, the SOROR score, simply applying it to CAR T cells, which I believe can be tough because, you know, we've been doing CAR T cells above age 75, and if you just select some in a, I would say, based on clinical judgment, things can be less complicated than in an allogenic setting. Where do you see the field going in terms of which criteria should we use? For instance, in the Charlson, score adapted by SOROR, a history of melanoma in your past medical history gives you, I think, 6 points. It's huge. But do we believe, you know, a history of melanoma in a patient, you know, a few years later with lymphoma candidate to CAR T cell is going to make a big difference? I don't know. I'm just asking a question. Dr. Oluwole, what are your thoughts?
Yeah, so the short answer is that there aren't sufficient data. Now, any validated instrument will be reasonable to use because all you have to do is gerrymander it a little bit, rather than the time that it will take to generate things from scratch and start to validate and all of that. So I really am not opposed to those who are applying some form of existing instruments in the CAR-T patients. And I know there are studies ongoing right now, and we will have more data very soon. So what I'll just say is that stay tuned, but I think the data are going to come in piecemeal, this consortium, that consortium, this institution versus that institution, but they will start to report on the impact of earlier measurement, and particularly the degree to which you can meaningfully intervene to be of impact in the CAR-T patient. So we need time to get the data.
Excellent. Thank you very much. Okay, in the last couple of minutes, my question to you, Elie, is, okay, you did this really amazing work, and again, congratulations.
Thank you.
What are the next steps?
So that are very good points. I think that the group now is seeking to have another part, which will be a registry, where we would like to compare how the use of the CAR-T cell therapy and how clinical indications are going to change ICU admissions, not only the prevalence, but also the way we are providing ICU care, and whether we could standardize the management of CRS and neurotoxicity. For example, tocilizumab is likely to become a drug that can be used outside the ICU setting, because when patients are with organ dysfunction, we know now, we have the background to say that we are in capacity of starting steroids. We are not going to harm CAR therapy for that. So, and we also know that tocilizumab has been recently demonstrated in a very nice paper about neurotoxicity, that it was a provider of neurotoxicity when we are treating patients for CRS. There are clinical evidence and there are experimental evidence in the two papers in Nature. So I would say that now we need to get more. There have been very nice advances in the way we stratify patients and classify them based on the grade. And I like the last classification that has been suggested, only based on whether patients receive oxygen, whether they need fluid expansion or vasopressors, and whether they are with fever or not. So when we do that, now we need to standardize therapy when patients are critically ill. And I believe that if we all do the same, we will have chances to reduce even mortality, not only short-term, but also mid-term mortality. Let me give you an example. We are not getting patients out of the ICU alive. We're seeking to have them getting out of the ICU with a normal renal function, because then yourself, you will have patients stabilized by day 90, but who will need maybe sometimes another therapy. And for that to happen, they need to be fit for that. And our role as ICU specialists is to work on fitness. We need to work on the fitness of ICU survivors. And this is something we are committed to work on in the future. And this is one of the major work that we want to implement in the next month.
So it's about the concept of a great fitness-free survival. Absolutely. Any last concluding word, Dr. Oluwole?
Yes, I want to echo what Elie said. There are some of the patients that progressed and died, whereas they were in the ICU. Again, who knows? Maybe earlier intervention, maybe better management, maybe they could have exited that ICU in a way that would be still with preserved ability to go on to another line of therapy. So I really do agree with him that we need to study these areas more and look at what things can be done to kind of reduce that mortality and the morbidity with which they exit the ICU in those who are able to come out. Thank you.
Thank you.
Well, that was really fantastic, gentlemen. I think you did a great job. Again, thank you for joining us. Thank you, Professor Azoulay, for sharing your thoughts. Thank you, Professor Oluwole, for being a panelist. And thank you all for the great work you're doing in favor of hematology patient. I mean, this is really an exciting era for all of us. And these CAR T cells have been really a true revolution and are bringing a lot of hope to many patients in need. And I'm convinced that we will use them more and more, and probably they will move into earlier lines of their disease. And we have also protocols now challenging the use of autologous stem cell transplantation in lymphoma, but also soon coming in myeloma. And maybe this will challenge also the use of allogenic stem cell transplantation in ALL. Why not? So really fascinating. Thank you all for joining the ICH Journal Club. Thank you for loyalty, and wherever you are, as usual, please stay safe and keep well. Goodbye.
Thank you.
Bye-bye.